Thank you so much. Hi, everyone. I'm Elizabeth Parsons. I'm a sleep physician here at UW and the VA, and I also trained here at University of Washington in my sleep fellowship. Very excited to talk with you guys today about sleep. We've done a couple of sleep academic half days on sleep apnea, and we wanted to give you some new content this year. We would really appreciate your feedback on how this goes. We want it to be high yield for you. And I now want to introduce Dr. Irfan. Dr. Muna Irfan is a sleep physician and neurologist at Minneapolis, VA, and she's an amazing teacher, especially on parasomnias. And we're very excited to have her speak with you today. And I'll turn it over to Dr. Irfan.
Thank you so much for letting me this opportunity. I'm humbled and honored because these sessions are always fun. So I hope this is useful for all of you, and feel free to, I believe Joelle is helping monitor the chat. So feel free to, if there's any questions or any points that you'd like me to highlight more. So without further ado, let's delve into a really fascinating and fun topic of parasomnia. That's part of the reason actually that I'm doing sleep now. So to me, it's fascinating, and I hope you also find it interesting as well. So I'll skim through the disclaimer slides. The main goal of our session today is to give you an overview, like a 10,000 feet view of parasomnias. And the objectives will basically include, objectives obviously are more specific. So at the end of this talk, I hope that the audience is able to understand the clinical presentation, the basic clinical presentation of parasomnia, and obtain relevant historical details for patients who may report some behaviors which may sound like it. Identify common triggers of parasomnia and understand the basic general type of movements or behaviors during sleep. Now, this objective is a little bit broader, but the goal of that is that, you get some sense of how to tease that out, at a prelim level without too much granularity. And the most relevant and important things for your clinical practice, what sort of counseling you can provide and when to refer to sleep medicine. So with that list of lofty objectives, let's actually go into, this is actually a sleep-based art, and I like to throw in a little bit of artistic flair to it too. So parasomnias, you don't need to worry about the actual definition. The simplistic version of that would be something unusual or abnormal happening within sleep. And it's a very broad term, but when we talk about behavioral aspect of it, parasomnias are abnormal behaviors or, experiences, physical experiential phenomena which emanate from or are associated with sleep. Typically, they manifest as motor behaviors, but the actual, physical description of that could vary a little bit depending on whether it's sleepwalking or sleep terrors, but it is some sort of physical behavior, could or could not be associated with vocalization. So that is what basic parasomnia is. I wanted to pique your interest. I wanted to start off with case because, why is it even relevant? Why are we talking to, medicine learners about parasomnias? So this is actually a real life case, which is obviously, without identifiers, which I'm going to read out, and perhaps, you guys can identify at the next slide what could be the factors. A college student has been studying quite late at night to prepare for his exams. He's getting only 4 to 5 hours of sleep per night. After he's done, obviously everything is behind him. He goes out with friends to celebrate at a bar and drinks more than a few beers. He takes a cab home and retires for the night. The next morning, he sees leftover food boxes in his room strewn all over the place. When he goes to the car, he notes significant damage on the car and as well as the garage door. He has no recollection of what happened. Review of the security camera footage shows that he had driven out of the garage at 3 a.m. and had returned half an hour later with food items. On his return, he drove straight into the garage door, and that's what resulted in damaging his car and the door. So, my first question, what are the factors responsible for his nocturnal behavior? A, sleep deprivation. 2, alcohol, big alcohol. C, increased homeostatic drive. D, OSA, obstructive sleep apnea. E, all of the above except D and F, all of the above. So you can start punching in your responses. We'll give it about 30 seconds. Excellent. You guys already know everything about sleep. So E is the correct answer. All of the above factors play a role into this nocturnal behavior, except D, because in the vignette, there was no sign and symptoms which could suggest he's a young college student. We didn't give the demographic of a person who would be at high risk of having obstructive sleep apnea, but sleep deprivation was at play. On top of sleep deprivation, you add mixture of alcohol, and there's already increased sleep pressure, meaning increased homeostatic sleep drive to be able to catch on that lost sleep. So all these factors play a role. Excellent. Now, next case. A 57-year-old female with diabetes and hypertension has developed snoring for the last few years with weight gain. For recent years, she has noticed remnants of food items in her bed upon awakening. This has included wrappers and also unusual food items, including her grandchild's candies, which she is not the person to, grab those during the daytime. Obviously not to be labeled as a candy thief, but she's usually very careful about her, dietary precautions during the daytime and is really embarrassed, not only about eating high sugar food, but also, obviously stealing the stash of grandkids' candies by these events, of which she has no recollection at all. So by description of that, you probably have already recognized what's going on. So sleep-related eating occurs in which of these following states of being? Relaxed wakefulness, N1, N2, N3, or REM. These are all different stages of being. I included the word being because we have also included wakefulness. So it's not just sleep stages only. But what would be your thought? Which one of these states this behavior is emanating from? Excellent. Again, the highest answer in terms of numbers picked is the correct answer, N3. So N3 is basically the slow wave sleep, and that's the stage where most of the time the non-REM parasomnias arise from. They can also occur in N2 though, but this is the most common one. Great. So the next case. A 70-year-old male is brought by his wife to the clinic for the complaints of thrashing about and hitting and punching in sleep for the last few years. He also shouts and uses expletives during these nocturnal behaviors. This is in complete contrast to his usual gentle demeanor during the daytime. She's obviously been concerned because of the physical behavior, and she has stopped sleeping in the same bed, obviously because of, being concerned. So during these episodes, now this is probably a difficult question, but for the fun of it, I thought, to still include it. During these episodes, the auditory threshold is increased, decreased, or remains unchanged. A, B, or C. What do you think is the right answer? So B is decreased is the right answer. And actually, a good majority of folks got it right. And those who got it right deserve an honorary sleep fellowship stature. So kudos to you. So what was described was REM sleep behavior disorder. We are going to talk about that later in the talk. But the auditory threshold in the RBD behaviors, the dream enactment behavior, is decreased. So that means that has clinical implication, because if the bed partner or the family member, gently reminds them, you're only having a nightmare, it's okay, they will be reassured. This is opposite to non-REM parasomnias. So we'll talk about that a little bit more in later along the course, but excellent.
Dr. Irfan, can I ask, for those of us who may not be familiar with the term, when you say auditory threshold, what is meant by that?
So what I meant was, our threshold to be able to hear, because in sleep is a state where all of our sensory modalities are sort of, diminished as compared to wakefulness. The responsiveness, as well as, being able to perceive, is diminished. But in this stage of sleep, or in this behavior, even though generally, we don't respond to, auditory stimuli, but in this stage of sleep, or in this behavior, we are able to perceive what is being taught to us in terms of the sound perception. Okay, so this may seem like a busy table, but before we talk about parasomnias, I wanted to kind of, give a little bit of framework of what could be the physical motor presentations. These are, not necessarily, we are not going to talk about those in detail, so don't worry about, really remembering what exactly it is. But I just wanted to give a framework that when we are talking about parasomnias, it's a combination of behavioral episodes as well as motor episodes and vocalization. So sometimes these could be intermixed too, and sometimes even getting the historical details could be challenging. So just to sort of help you get a framework in mind before we delve into the details of the parasomnia, I wanted to just list these. So the movements which could be noted when somebody is sleeping could be of varying degree. Simple movements include hypnic jerk, which is sort of like a sudden myoclonic jerk right around the time when we are drifting into sleep. Almost, I would say more than 70% of us, even in the audience, would have experienced that. That's not alarming, that's benign. So not something to worry about. But if somebody has really very prominent, strong physical hypnic jerk, the bed partner maybe could be alarmed. Bruxism is also simple movement, which is teeth clenching. Fairly common. Leg cramps is also a relatively simple movement, and people can describe that as a sudden, twist or cramping of the muscle. They could be notoriously hard to treat, though, in actuality, for people who may be afflicted by them. So these movements, could be described a little bit or, perceived a little bit easily. And then periodic movements are basically the type of movement which recur at a certain, duration of time. That's why they're called periodic. So periodic limb movements is one example of, recurring, repetitive, after a certain interval type of movement. And they generally are more prominent in limbs, but if they are a bit stronger, then sometimes, the momentum from that may appear to spill in the other regions of the body. Rhythmical movements are more sort of like, behavioral rhythmic movement of body rocking or head banging, more common in kiddos, in peds, much less common adult population. But this is more of a behavioral body rocking or head rocking is more of a behavioral movement. It's different from the complex movement of stereotypical movement of epileptic seizure. So when we are talking in terms of in sleep-related movement of rhythmic body rocking, that does not have connotation of epileptic type of episode. Now, vocalizations could be of various types. I've just included a couple of examples, but sleep talking itself, if it's not associated with any behavioral, physical, physically aggressive episodes, then somniloquy or sleep talking is a benign variant, if you will. Just to remember about that. But if it associated with other complex behaviors, then that would be the time when we would need to get a little bit more history and tease things out. Complex movements are basically, they could comprise a host of complex things, but in order to keep it, simple, think about when do you really have to worry about, and that would be the time if you are afraid that it could represent epilepsy. So epileptical movements would be stereotypical, recurring, and will have the same semiology, exact same semiology. So the key word I would encourage you to remember would be that exact same stereotypical physical movements and repetitive and recurrent. Psychogenic events may have same theme, but the actual description of the episode itself is not going to be exactly same. So again, this framework, you're not going to be tested on any of these, but I wanted to kind of, just give you an introduction of, what could be the mimics or what could be a few movements which can, make the evaluation of these parasomnias a little bit complex. Now, this slide is again very busy. I wanted to keep it still included for your reference. You could go back to it, in case when you are dealing with the complex sleep-related behaviors, just so it will give you, broad categories. In general, what I would suggest you to really pay attention to would be this, broad differentiation of non-REM parasomnia and REM parasomnia. So sleep is divided into different stages of sleep. Non-REM sleep is N1, N2, N3. And then there is REM, which stands for rapid eye movement sleep. Now, if you look at this table, non-REM parasomnias, and we are going to talk about that, in detail, but they include the commonly encountered sleep-related behaviors of confusional arousal, sleepwalking, sleep terror, sleep-related eating. Sexsomnia is talked much less about, but these ones share clinical characteristics, pathophysiology, even though physical behaviors may be slightly different, but they share many of those factors. And these are what you will commonly come across in the clinics. More so most of these are more common in pediatrics. We're going to talk about that in detail. REM parasomnias, between the REM parasomnias, I would say you will come across, but it's much less rare. Sleep paralysis, you would have probably even noted amongst yourself. We are not going to talk about each of these parasomnias, but we will touch upon RBD, the REM sleep behavior disorder today, because of some important implications, but that's going to be much less common. The other parasomnias are sort of, again, you may or may not come across that, but I would suggest, obviously for the sake of the brevity of the time, probably the focus between non-REM and REM parasomnias would be appropriate. And then if you worry that there is another parasomnia which is bothering a patient, then that would be the time to refer to sleep clinicians. Now, delving deeper into non-REM parasomnias, non-REM parasomnias are characterized by abnormal nocturnal behavior, impaired consciousness, and autonomic nervous system activation with impaired arousal. So this is the broad definition. Don't have to worry about broad definition, but think about that this type of nocturnal behavior, people have impaired consciousness, they have partial recollection, and it is associated with some sort of abnormal physical behavior as well, and also sometimes associated with autonomic nervous system. This is not a poll, actually. Just wanted to clarify. And the main non-REM parasomnias include confusional arousals, sleepwalking, sleep terror, sexsomnia, sleep-related eating disorder. Again, fourth one is talked much less about, but I wanted to just keep in there. So if you're concerned, then I would say just, consult sleep right away at that point. This table includes the diagnostic criteria of disorders of arousal. When I'm calling these disorder of arousals are basically the non-REM parasomnias. And this is the general criteria which will be applicable to all of these 4 or 5. So what would be the criteria, even though it may look like it's a list, so you have to commit to memory, but basically this was included in the definition itself. So there should be recurrent episodes of partial awakening, when we say partial awakening from non-REM parasomnia, think of that as the easier way to remember would be that the person is partially awake, but not fully awake. Part of the areas of the brain are sleeping and part of the areas of the brain are awake. So that basically explains why do they behave in this manner. So recurrent episodes of partial awakening, inappropriate or absent responsiveness to the redirecting effort. So, I mean, they may appear like they're sleepwalking, but if somebody calls out their name, they're not going to be responding. Limited or lack of cognition. So either they will be not really aware of what's going on, or even if it appears like they may be partially aware, they will not have any remembrance of that. So that was the fourth point, partial or complete amnesia. And there may be also some snippets of imagery, dream imagery. Back in the day, we used to think that there's going to be no dream mentation at all. But there have been multiple case series and case reports that they could be snips of dream imagery, but it should not be very vivid or very detailed or elaborate. And the fifth one is it should not be caused by other external factors, such as mental health, medical issues, medical conditions, or medications. So that's the last one, which is more sort of like not being caused by other extrinsic factors. So these criteria should be for all of these disorders. Now, going through the basic, common characteristics, which is basically the pathophysiology, what causes them, why do they even occur, and then what are the precipitating factors? And I think it's important to know what are the precipitating factors because they are tied into how you would even treat them or how could you prevent them. So why do they even occur? One, it occurs on the basic substrate of, some brains are hardwired. They're more vulnerable to develop these versus others. But the actual pathophysiology of how it's happening, this is a simplistic version, what I am going to describe to you. But again, as I was referring before, that think about, that these are think of it as partial arousal. When we drift from different stages of sleep from one to the other and even to wakefulness, it's a very carefully orchestrated system. So from sleep to N1, N2, N3, REM, and then sometimes we wake up or we go through this cycle over and over again. But in non-REM parasomnias, what happens is that there is not that smooth transition from non-REM to wakefulness. So there's incomplete dissociation, meaning that some centers of the brain are, waking up. There is high activity there, but the full brain cortex is not yet awake. For example, in sleep-related walking, the area of consciousness in the brain is still sleeping, but the motor area of the brain has high wakefulness type of activity there. So the person may physically start walking, but then the other areas of the brain, the frontal cortex is sleeping. So they would not remember what's going on. So think of that as partial awakening with some areas still sleeping. And that's what leads to this presentation. The other two factors which I've described here, they are much less commonly discussed. And I would say, they're more interesting. You will never be tested on those. But there's also some people have this sleep state instability, if you will. And the cyclic alternating pattern is a marker of sleep state instability. Often, and these parasomnias are often associated with these type of, alternating arousal microstructure of the lighter stages of sleep. So the easier thing to remember would be that some people have sleep state instability in the form of this cyclic alternating pattern. The abbreviation of that is CAP. And another way to think about is also, some of these complex behaviors are associated with the central pattern generators, which are not in our conscious brain. They are located subcortically. Again, this is talking a little bit more in depth, but coming back to, I think the easiest way to wrap our heads around would be that there is incomplete dissociation from one stage of non-REM into wakefulness. Now, there's also the other thing which I wanted to highlight, which is also going to be relevant for you guys, is that there this is because of complex interplay of predisposing, priming, and precipitating factor. And there I will take, a minute to kind of describe that. So predisposing will be, as I was suggesting, that sometimes our brains are hardwired, they are more vulnerable to develop this. So that could be, for example, predisposing. And then priming factor is, some factors which kind of set the stage. As I was explaining in one of these cases, that college student who is really sleep deprived because of studying, and then that, sleep deprivation, which is going on for a few days, that is priming factor for him. And then precipitating factor was, that sudden alcohol use. Now alcohol is sort of like, a CNS depressant for him. And also alcohol withdrawal causes, in the middle of the night, causes awakenings or arousals. So he has high pressure to sleep. So that would be priming factor because he's so sleep deprived. His body is wanting sleep, but then the alcohol levels dropping down, or that alcohol withdrawal in the middle of the night, that is causing those arousals. So this interplay of priming factor and then precipitating factor leads to development of these non-REM parasomnias. So it's, again, to simplify that, some of these factors between the predisposing, priming, and precipitating factors will be deepening the need to sleep. And on top of that, there will be other factors which are fragmenting the sleep. So this complex interplay of some factors trying to deepen sedation and other factors trying to wake us up, that will lead to the emergence of these behaviors. Okay, so this is what I meant here by precipitating factors, conditions that result in sleep fragmentation. They could be the precipitating factor, which on top of the heightened drive to sleep, which is basically the homeostatic sleep pressure, and a combination of these two both will lead to non-REM parasomnias. Okay, now enough about the pathophysiology. And let's talk about the actual behaviors. So confusional arousal, these are basically characterized by, disoriented behavior, partial awakening, and disoriented behavior during an arousal from non-REM stage of sleep. Sometimes, associated with vocalization, and definitely there's no recollection or very poor recollection by the patient themselves. Much more common in peds, prevalence could be anywhere up to 17%, much less common in adults, though people outgrow it, generally over time. So what are the diagnostic criteria? According to the International Classification of Sleep Disorders revised text, the criteria for disorders of arousal, which I went earlier in the slide, they should be met. But the additional ones are that there are episodes of confused behavior, but the patient is still in bed. So again, don't worry about this diagnostic criteria. The idea is that as long as you understand that a clinical presentation looks more in the ballpark of confusional arousal. So what would it look like? Maybe it's, 7 or 8-year-old who is sleeping in his bedroom and the parents are watching with a monitor, sometimes when parents really want to be careful. And then they see that the child is sitting up in the bed and is, trying to look at something in the blankets, or is, just looking around very confused, maybe lets out like a mumble or so, and then goes back to sleep. That is what typically confusional arousal will look like. So that is not a seizure type of behavior. That is a behavior which is classic of confusional arousal. The number 3 point is just to differentiate it from sleep terror or sleepwalking. So again, don't worry too much about the details of criteria. They're there just to kind of help you as a reference. Let me try to play this, and images speak louder than words.
Dr. Irfan, if it's not working, if you might try clicking on it one more time, and let's see if we can make it work.
Oh, it's not working for the audience?
It may be that you may need to close your presentation to show it, and it may need to pop up on another browser.
Gotcha. Okay, let me try.
We're not seeing a video right now.
Okay, let me.
If you scroll to the slide where the link was, we can try one more time.
Okay, I was gonna stop sharing and then share again. Maybe.
If you have it open but not in the presenter mode, and try clicking on the link, let's see if that works.
Okay. Is this working now?
Go ahead and hit. We can see the video. The audio is not playing, but that's okay.
Okay, this one does not have much in terms of audio other than description. So you see how this child woke up, there's EG running in the background and he's looking up at the ceiling. This child was suspected of having seizures. The tech comes in and tries to talk to him. And he's just mumbling. He did not answer the tech's question.
Perfect. Thank you.
Okay, let me unshare. Let me unshare and I will go back to sharing. Can everybody see my presentation now? PowerPoint?
We can. It's not under presenter mode. That's perfect. Thank you.
Okay. Thank you for pointing out. One never knows how the videos are gonna pan out. But I think that case kind of gives a good representation that, you know, historical details in kiddos may be hard, and family was really distressed that he may be having seizures. So now let's talk about sleepwalking. Sleepwalking is combination of still impaired consciousness and, you know, an episode emanating from sleep, partial arousal from sleep. So the person gets up from sleep. It may look like to the bystander that he's awake, but their brain, the thinking, the higher cortical neurons are still sleeping, but the motor area of the brain is active. So that results in walking episode. So sleepwalking is combination of ambulation with still persistence of impaired consciousness after a partial arousal. Prevalence is again much higher in pediatric population. You know, depending on the source you're looking at, it could be as high as like 29%. And the behaviors basically peak at the age of 10 in adults, much less common, but still they can occur. And the consequences of that, obviously, you know, goes without saying that it can really lead to sometimes injuries. If somebody goes out of the home in sub-zero Minnesota temperature, you could imagine, you know, what the implications could be. And then, you know, people can sometimes even end up driving the car as a continuation of that, which can definitely lead to much more graver consequences. Just like the example of the case I gave you, at least in that case, you know, the patient was still safe enough. Now, the criteria for sleepwalking, again, the main general criteria for disorders of arousal should be met. And the additional is going to be that the episodes consist of walking, ambulation, and then, behavior out of the bed. People have gotten up and, peed in the closet, for example, rather than going to the bathroom. So, it can result in unpleasant consequences and sometimes grave. Now, what are the aggravating factors for sleepwalking? As I had alluded to in the pathophysiology, that some factors which deepen sedation and some factors which fragment sleep. Both of these could precipitate the occurrence of these. So, in terms of now thinking about the practical points when you're getting history from the patient, think about obstructive sleep apnea. That would be a factor which can fragment their sleep. Think about restless leg syndrome. Again, that could be a factor that can fragment their sleep. And then, a big one for you guys is different medications. So I would really, really caution you, to pay close attention to the medications that are on their list. And even, I think, more important is medications which are not on the list, because they are notorious to be missed easily. Obviously, but the classic medication which you really need to be aware of are the Z drugs, the benzodiazepine receptor agonist drugs. So zolpidem, zaleplon, esopiclon, all of these can aggravate the sleepwalking behaviors and other parasomnias. Antidepressants can also cause that, though. Amitriptyline, bupropion, paroxetine, mirtazapine. Antipsychotics can also cause especially sleep-related eating also, in addition to sleepwalking. Quetiapine and olanzapine have, significant, really high number of cases, but it could happen with other antipsychotics as well. Antihypertensives, propranolol, metoprolol. We don't usually think of antihypertensives, as causing, sleepwalking. Generally, our default also goes back to Z drugs, but there are case report and case series for these beta blockers as well. Some antiepileptic agents, such as topiramate, has also been known to cause that. Anti-asthma agent, montelukast, is one of those, and antibiotic, again, rare. These are less common, fluoroquinolones, but it can happen. So, just wanted, I think, especially as you guys are going to be, their first point of contact, it will be really helpful to review these incriminating medications. Just to add a touch of art, this is a depiction of a sleepwalker, a somnambulist, by this famous English artist. But I also, it's sort of like, not only it's a nice piece of art, but I also wanted to kind of put it out there because in media and art, sometimes the depiction of sleepwalkers are, more romantic and fantasized. You would come across in maybe classic movies where the sleepwalker is walking with his hands in front, or they're sort of like, walking as a ghostly appearance. But in actual practicality, they will not have their hands outstretched because there's no reason to do that. In actual practicality, they would appear like they have gotten from the bed and they are walking, to go grab some drink or go to the bathroom. It will not have an otherworldly appearance to that. Anyways, so let's move on to the next one, sleep terror. So sleep terrors are episodes of intense fear. It will appear as if the person is awakening with a sudden cry or loud scream and really inconsolably crying. And this one is associated with autonomic nervous system activity. So they will have, tachycardia, tachypnea, pupils would be dilated. So in sleep terrors, the subject or the patient will have really, it would appear kind of distressing. As you can imagine, following the same, much more common in peds, much less common in adults. Peds could be as high as in 56%, depending on what source you're looking at. And but much less common though in adults. But as you can imagine, this would be really distressing to the parents. If a child wakes up with inconsolable crying, that would be really, it's really hard to sleep with peace as a parent, as an adult there. Again, the criteria is same as the disorders of arousal, but this one will be characterized by abrupt terror, alarming screaming and crying. And in addition to intense fear, the autonomic arousal, pupillary dilatation, tachycardia, tachypnea, sweating, that would be associated with that. And let's see if this video plays.
Dr. Irfan, the video is playing, but the audio, if there's an audio, it isn't playing. If you don't mind describing what the sound is
Sure.
playing.
Sure. So let me actually take it back a little bit. So this person is being monitored in the lab, and then there's a sudden, let me play it and describe. So there's a sudden background noise, auditory stimulation, and the person, as he's really taking off the leads at that time, he's really screaming and he's really terrorized, all of a sudden, as if he's startled. And by this time, now he's awoken completely, but before he was still partially in that sleep terror state. But now he's realized that he's taken off the leads and there's no harm, but still it took him like, 20 seconds. By the time the tech comes in the room, by this time he's realized what happened. But right at the time when he took off all the leads, he was very scared and he let out a scream at that time. Again, much less common in adult population. As we were talking about, the days of media consent, I couldn't come up. I had the PEDS videos, but those were the classic videos, and I did not have consent, so I could not share. But more classic one, what you will see in kiddos is gonna be they will be just crying their eyes out. And they would, if you try to intervene, if you try to redirect them, they will not be responsive to your efforts. If anything, it can lead to more agitation in that cases. Okay, so sleep-related eating, basically this one manifests with nocturnal eating without any recollection. The person would get up, it's a combination of to a degree sleepwalking, and then they will go, and the unique feature of this is going to be that generally they will have propensity for carb-rich food items and also some non-edible items. So for example, they may butter a soap or cigarette butts. People have eaten strange combination of things. And that's one of the criteria. Again, I put the criteria down there as more of a reference for you. You don't have to remember each and everything, but the main hallmark feature of this is going to be recurrent episodes of, eating after arousal, partial arousal from sleep. And the consumption of the food is going to be, peculiar items. Maybe they are putting, Nutella on chips or something like that. Peculiar combination of food items and sometimes even inedible items, but generally carb-rich food. They're never gonna go for salad at all, even in sleep state. For some reason, I don't know why humans are we are hardwired to like non-healthy food. So anyways, and as you can imagine, it can lead to unpleasant, again, they will have partial or complete loss of consciousness, but it can lead to, consequences. A person who's diabetic, obviously it's going to throw that off the chart, or it can lead to weight gain and even, dental caries, because obviously at that time they eat sugar-rich food and go back to bed. Prevalence of that could be anywhere from 0.5 to 4.6%, according to Brian. Aggravating factors, are same as the other activating factors we talked about in the pathophysiology. But then there are certain medications in addition to Z drugs, which I have listed here, which can increase the frequency of that, and that includes mirtazapine. Quetiapine is already included in antipsychotics, but I kind of, to highlight the importance, I included that again. Lithium carbonate, benzodiazepine drugs, and anticholinergic medications can aggravate that. Combination of restless legs plus Z drugs. Classic for sleep-related eating. If you see anybody in your clinic who is reporting some sleep-related eating behavior, always, always, always look for restless legs history and yes or no to the Z drugs. So in the interest of time, I think we should continue moving along. Sexsomnia I've put in here because that's, included in later years, and generally we don't talk about that. But again, think about all the non-REM parasomnias as, primitive behaviors emanating from sleep. As I had mentioned, that our frontal lobes are still sleeping, but some areas of the brain are awake. So we go back to our primitive instincts, right? What were those? Eating, obviously other primitive behaviors. So sexsomnia is again, deriving from that. But I would really caution you that this is again not a familiar territory for some people, even in sleep. As I said, formally described only in 2007. And the classification was updated in 2015. And the integration into the International Classification of Sleep Disorders textbook, it did not happen until later. So I would suggest if you hear anything about that, don't even bother, because then there are forensic implications, right? So best to refer to sleep medicine right then and there. Abuse or not and all that. Yeah, I could talk about a number of forensic cases, as you can imagine, here. But I would suggest you, as in medicine, if you hear about that, just straightforward referral to sleep. There are actually some forensic sleep specialist experts, nationally, who take these really tough cases sometimes. Now, evaluation of non-REM parasomnia, I would say, after talking about all these, what are, the main points for us? Clinical history, detailed witness account, very, very, very important. So, and I would say always get collateral history. If it's an adult patient, he's come alone, I would suggest that, you call their bed partner right from the office, because that'll save you much time and, much thinking process to trying to figure out what actually is happening. And if possible, obviously, and and also detailed account of these episodes from the patient themselves too, including their usual sleep schedule. What time do they go to bed? What time do they wake up? What is the typical sleep schedule on the work days and on the off days? And that will give you idea whether they are sleep deprived or not. If they are taking naps, what is the general duration of sleep when they are not having these episodes, and if there are any sleep disrupting factors, such as, history of obstructive sleep apnea, such as history of restless legs, and external disruption too, right? If they have really busy schedule, sports season going on, and they are really going to bed late, or if they are traveling from East Coast to West Coast or something like that. So any external factors, I would say. Even sometimes I remember there was a hairdresser who started having these episodes, but then we realized when talking in detail that she was going through busy wedding seasons, and she was obviously taking on a lot of wedding parties, and she was not sleeping well. So I would say take detailed account of the episode itself in context of their sleep and wake schedule. That is extremely important. And then aggravating factors, history of aggravating factors, including the med list. Sleep study can help. I've put the finding there, but you should not have to worry about that, because you're not obviously a sleep clinician at this point. Maybe in the future, which is very exciting. But I would say sleep study can be indicated in some cases, but more so in those cases where you are concerned about whether they have, obstructive sleep apnea as an incriminating factor. So their sleep study, I would suggest, yes, you could consider it. But if the history is very classic for one of these parasomnias and there's no concern for sleep apnea, then it's not mandatory. So in non-REM parasomnia, key point, I would suggest sleep study only in the cases where you're concerned about other sleep disorders. Otherwise, or if the person is having violent parasomnia, then that would be the other reason. But otherwise, you don't have to. It's not mandatory. Review of the offending drugs, I would say hands down, that's the thing that we should definitely do. Actually, FDA warning came out in 2019, but even long before that, we already knew that the Z drugs can aggravate that. Management of parasomnias, I also want to spend some time there. Even if it's a case where you feel like, okay, you have gotten some idea, but then you want further help from the sleep referral, this basic management, you could start in your office right there. And I think it's very important because it may take them several months until they will be able to eventually be seen by a sleep clinician. So environmental safety, key thing. I would say everybody, regardless of the type of parasomnia, making sure that their environment is safe. That could include making sure that the doors are properly locked, the windows are properly curtained and secured, and even for sleepwalkers, having motion sensor alarm, because they can unlock sometimes the door as well as a result of their automatic behavior. So motion sensor alarm at the front door, so they don't walk out to the threshold in sub-zero temperature. Environmental safety would be the key thing. Making sure that the weapons in the room or in the household are properly locked away in lockers. Very, very important. Very, very important. So environmental safety, I would say, hands down, universally, you should advise them right then and there. Treatment of incriminating factors, if you notice that they are on these medications, then definitely trying to consider reducing or replacing these meds. And if you are concerned about other sleep disorders, OSA, RLS, then definitely refer them to sleep right then and there. Ensuring proper sleep duration. If you've already identified that this person used to generally sleep for 8 hours, but now they're consistently sleeping for whatever reason, they are sleep deprived to 4 or 5 hours or any number of hours, that counseling you can do in your clinic right there. Advise them to try to get the proper duration of sleep, which is easier said than done, but the sleep clinician is definitely going to come back to that. Behavioral therapy, when it comes to that, there you would need a sleep clinic referral or a sleep psychology referral if you happen to have access to those, but those you may not be, directly in communication with the behavioral psychologist, who may be at your institute. So behavioral therapy for sleep, for parasomnias, I would say you will have to go through your sleep clinic. Hypnosis is done for kiddos, anticipatory awakening. If the nocturnal behavior is very timed, then anticipatory awakening can also help. Meaning, like if it tends to happen, like, maybe at 11 o'clock, then alarms can be set like, 15, 30 minutes before that, and to awaken the child, and then, letting them sleep. There's not data in adult population for anticipatory scheduled awakening, but in kiddos, it has helped. I believe I have 5 minutes now. So I will try to cruise through a bit quickly. Environmental safety, we already talked about. Secure windows and doors, maybe having, a soft mattress on the floor. This is for the other parasomnia, which I'm going to briefly talk about, which is the REM parasomnia, and the main implication for you guys. Now, there are pharmacological treatment as well. I've included the table here, but generally I would suggest that, leave that to your sleep specialist at your institution, because again, then there are several implications of that, the minimum dose, and, obviously making sure that the side effects are not happening. So as you could see, non-pharmacological behavior treatment includes treatment of coexistent sleep conditions universally. So that's the key point here. And anticipatory awakening in kiddos can help in confusional arousal, sleepwalking, as well as sleep terror in kiddos. But the treatment of coexistent sleep condition helps in all of these cases. Again, pharmacological, I've listed here for your reference. Clonazepam, you can consider that steroid of the sleep world, if you will. But in sleep terrors, there are a few other medications that could be tried as well. Imipramine, trazodone, paroxetine. Again, I would lead that to your sleep physician. Sleep-related eating, again, treatment of coexistent sleep conditions, aggravating factors, and that stands true for all. But pharmacological agents, again, I've listed them here only for your knowledge, but otherwise I would keep them there. Now, the other one, last couple of minutes only, what I wanted to spend was on REM sleep behavior disorder. So REM sleep behavior is a disorder of abnormal motor behavior in REM, which is manifested as dream enactment behavior. This behavior is relatively going to be relatively rare, but the key thing for you to remember is if the patients have vivid dream and they start acting them out, that is abnormal. And if you hear about that, then that would be the time to refer to sleep medicine. This is the only parasomnia where we need to get a sleep study for all the cases. So that is one thing, if you can take that point home.
Dr. Irfan, I have it queued up. If you want me to, I can play it.
Thank you so much. That would be super helpful. Do I need to just stop sharing, or you can share on top of
I will take care of it.
Okay, perfect.
Give me one moment here.
So as you saw this patient, this case, can you imagine being bed partner to a person? What he was doing was acting out on a dream of hostile connotation. He was dreaming that somebody was attacking him or fighting him, and he was trying to hit back at the perpetrator. So imagine, this type of behavior could have grave consequences. RBD can be divided into different types. I'm not going to go into the details of idiopathic or secondary, but you can think about idiopathic is without any other neurological disorder, and secondary is generally associated with neurological disorder. So why is it even important? What are the implications? I would want you to remember two things. And again, you will have access to, to this material. But one important implication is safety. So this is with permission of, this is a personal patient of mine, and he gave consent to show this. This is what happened when he was dreaming and he started fighting and he fell off the bed. And this is what ended up happening on a different day to the same patient. So he punched a hole in the wall as a result of fighting in his dream. So you could imagine how injurious it could be, not to the patient only, but also to the bed partner. So the implications of these are going to be, one, safety, huge, 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 so you should definitely start the safety counseling when you hear about this type of behavior in your clinic, because, we don't want to lose time. And then the other implication is that these patients may go on to develop some neurodegenerative disorders. Not going to talk about what type, but I've listed here. So yeah.
I'm so sorry to interrupt. We don't see your slides anymore.
I'm sorry.
No problem. And we can take a few minutes. We can go for about another 5 minutes. If you need to finish up, we'll take it out of the breakout.
Okay, perfect. Perfect. So I thank you for pointing out, because I think what I was talking about in terms of pictures was not visible to you guys. So now everybody can see my slide?
Yes, you're not in presenter mode, but we see your slides. Yeah.
Okay. Okay. So this is picture of the gentleman I was referring to. And this is with his permission and consent, obviously. So you could see this resulted when he fell off the bed as a result of fighting in response to a hostile dream he was having. And this is the same patient's bedroom wall on a different night. So this is what I was referring to, that the huge implication for these cases are going to be risk to themselves and risk to their bed partner. And the other implication, which I was referring to, was a risk of development of some neurological disorder. So the safety counseling, you should start right when you hear about this in your medicine clinic, outpatient clinic. And then, you should refer to the sleep clinician to take on the further discussion about the future risk of phenocomversion, if at all. I would not obviously start the discussion right at the first visit, because that will scare the patients away. So leave that for later, but it is really important not to miss that, because as you can imagine, anywhere from 81 to 90% of the people can go on to develop a neurological disorder, a neurodegenerative disorder. So I would not, this is for your own knowledge, not to share with the patient at the first visit, obviously, but this is a really high percentage. So we don't want these patients to fall through the cracks. Only one caveat, their antidepressants can also sometimes unmask dream enactment behavior. So if you see an antidepressant on the list of medication, do ask them about the timing of this type of dream enactment behavior, and what time was the antidepressant started, because that will also help the sleep clinician to tease things out. Now, management of this, I will briefly, what I wanted to mention was that environmental modification, key thing. You definitely should do that. If you are at a place where the access to sleep clinician is very tight and you anticipate that they're not going to be able to see them for a number of months, then melatonin is a medication that you can consider starting them on. I have listed what the other medications could be used in those cases too, but generally I would leave that to the sleep clinician. I would not want to, obviously, I would advise against using the other ones, because then the situation can get muddy. And if anything, if you think about most of these patients going on to develop neurodegenerative disorder, you don't want to take on, prescribing clonazepam to a person who may be developing dementia of some sort of already. Quasi-sitter alarm is another way to ensure safety. So basically, this is a bed alarm which senses through pressure. If a person suddenly jolts up from the bed, the bed sheet, the sensor will sense that. And what happens is that the family member can record their voice, reassuring voice, hey, Sam, it's only a dream you're having, nothing to worry about, go back to sleep. And that's where that reduced auditory threshold helps us in REM parasomnia, that the person will be responding to this and they will go back to sleep. Again, it helps only in those patients who may, get up, or who have, jolt up from the bed. If somebody's laying flat on the bed and then swinging about, then in those cases, it's not going to help. But this is one key thing that is different in REM parasomnia as compared to non-REM, that in non-REM parasomnia, I would advise against redirecting the patient. Just make sure that their environment is safe, and let that run through course, because if you try to redirect them, they may be agitated towards you, because remember, they are only partially awake. They will not have intact cognition. So very busy table, these ones, but this is for your own reading pleasure, which helps you in differentiating some of these features. PSG characteristics, again, I think that's very detailed. That one is for those of you who are interested in becoming sleep fellow in the future. For rest of you, take it as a reference guide mostly. Now, takeaway points from the discussion today. Not all sleep-related movements would be parasomnias, but if there are parasomnias, if you are concerned, then try to take as detailed history, as meticulous history as you can. Definitely include the collateral historian. If they happen to take video on the cell phone, that's even better. But the regulations around how you would put that in your notes, or how would you document that, would vary according to your organization. But meticulous history, collateral history, extremely important. Ask about triggers, ask about aggravating factors, relieving factors, sleep schedule, very, very important. And safety counseling is definitely within your role, definitely within your wheelhouse. Do not ignore that. Even if you're not 100% sure what is it, safety will never hurt. So, that I really wanted to, highlight the importance of that. Refer to sleep medicine for other suspected sleep disorders, for persistent behaviors, for safety concerns. Even if you've addressed and you hear, for example, if you've identified a Z drug as an incriminating factor, you can obviously advise the patient to reduce it in conjunction with the prescribing person's input, and then reassess. If still behavior is persistent, definitely consult sleep if the presentation is unclear. The last point which I wanted to bring, despite of some of these pointers we discussed about, maybe it's a person, an 80-year-old who lives alone. Maybe you do not have a good collateral historian. Maybe you don't know whether this is just, delirium in an elderly patient because now he has also cognitive impairment. Our patients don't read textbooks, right? They definitely have not sat through the presentation today. So if the presentation is unclear, definitely consult your sleep colleagues. I can assure you they would be happy to see these patients. So sorry, I took a little bit more time than intended, but this is a very vast topic that we have kind of, packaged in this session today.
Thank you so much, Mona. I think we'll probably go straight to the breakout sessions. We'll have 20 minutes. Jabal will put us in. Dr. Irfan will be one of the room leaders. You'll have a leader for each room, and make sure that you have your breakout session guide with you and the learning pearls, because you'll want to refer to that during the session. Thank you so much, Dr. Irfan. I always learn more from hearing from you.
Pleasure.
Okay, so as Dr. Parsons said, I'm going to open the breakout rooms right now. I have set a timer for 20 minutes. Don't worry, when that timer hits 0, it's not going to close the rooms automatically. I will then give you 30 seconds so that you can wrap up, and then it will automatically dump you back in the main room. Great.
Nikki, someone's coming back
I
in.
pressed the wrong button. Could you put me back in by chance?
Yeah. Do you see a button to rejoin?
No.
Because-
Maybe. Yes, I do.
Great. I was gonna say I can't put you back in there. There is a button.
Nikki, just so you know, the intro session was probably a little denser than we really were hoping for, perhaps. It was introduced as a sort of high-level overview, and it got deep into the weeds.
Yeah, I logged on at like 9:50-ish, and man, that was
yeah, it was a little
I feel
dense.
like we have to be like, what is a parasomnia? Like,
No,
what?
right? And just so you know, I was actually texting Elizabeth during the session and suggesting that it's not entirely clear. It got a little clearer at the very, very end why there's this distinction between REM related and non-REM related. Like, she very early went to sort of like, oh, these tables with here's the difference between them. And it really wasn't until the end when showing the videos where it's like, okay, I could see that that's actually important to, but it was kind of like this academic distinction between them at first, and it was very unclear. And then we were having trouble with the videos. That's why in the very end, I actually had it up and ready to go, because 2 other videos, one didn't work that well, and neither of the other ones had sound. And so we didn't actually know that those were going to run. Elizabeth is cued. She's actually much more responsive to sort of these sort of things. So if there are things happening along the way that you're noticing, if if you message her, she's really responsive usually. I think that what happened is that I suspect that the first speaker is very well respected in the field and not someone that she probably had a lot of, it seemed like she didn't have a lot of input in how it was all put together. That's the sense.
You know,
It's okay.
things happen.
Well, one of the polls was like, which phase of sleep is this? And just by chance, the group picked the right phase. It was like N1, N2, N3, or REM. And the right answer was N3 phase, and it happened to be the plurality, not the majority, but the plurality. And so she goes, "Oh, okay, so people got this," and then moved on. And I was like, "Wait, I don't actually know what N1, N2, and N3 are. I don't remember exactly what those are. I remember that there's non-REM phases, but like it was, I think, pure chance alone that they got the right answer."
You know, it's hard because I think specialists want to think generalists know more about their topic than they do.
Oh, totally.
And I actually think, as I've been doing like more speaking this year, the level, everyone appreciates a more foundational approach.
Oh,
No
yeah.
one will ever complain about like even something like AFib. Wouldn't
Yeah.
you love a talk that was like, well, what really is AFib? Like, let's talk about that again. Like, no one teaches you that after your first year of med school. And then you're sitting there one day and
Yeah.
the patient asks, and you're like, well, what really is happening? Right? Like,
I know.
what are the foundational parts of this? Yeah, but it's a good idea of like even having an overview of like sleep.
Right?
So
Totally. Like it's like, here's what normally happens in sleep. You go from this phase to this phase to this phase, and this is how we distinguish them. And again, it's just again, I think Elizabeth is very, very mindful of like and responsive. So if stuff is happening that you notice, just send her a private chat and she can try to help troubleshoot it.
sounds good.
So it was invisible to Javel, but I was like sort of panically texting her. I'm like, the videos aren't working. Do you have the other ones to come so that I can get them queued up? And we're working on it. It's fine. It's fine. People will be fine. I hope your meeting was good.
Yeah, I don't know why we do it at this time when one of the chiefs is always gonna be pulled in another direction. But
It's okay, actually. It's one of those things that I say it every year, although who knows if I said it last year. Renata came to me a couple of years ago and asked if that was okay. And I always said it's fine, right? Either John or I will always be here. So
yeah,
Genevieve doesn't have to ask every month. Like it's on the spreadsheet. I'm aware of it. Like it's totally fine.
But I to your point though, I don't know that it has to be at this time. I have chosen not to make a big deal of it. It's sort of like I don't know. One of the thoughts that we had, and it kind of went nowhere, is there was a conversation at some point during the year about in the future flip-flopping academic half day. I think we may have raised this question, like to the afternoon rather than the morning. And the idea was that in the afternoon, rather than everyone rushing off to clinic, you could come in and then you could all like afterwards go out and like
socialize.
Right? And so there's good reasons for it. It turned out to be a huge mess in that, and I knew it was going to be in that. Then you have to go clinic by clinic, and you have to make sure that staffing wise that they've got the right. I mean, it takes time to flip flop something like that. It's not something you can just do. When we started talking about that, I was like, well, let's just drop this question about when the chiefs meet and all that sort of stuff. And so now that we're not doing that, it's sort of like back on the table, but it's kind of like, it's just one of those things where it's like too many other fish to fry.
Yeah, I like the afternoon idea. Most programs do their ambulatory teaching in the afternoons.
Yeah, you know, it's a total remnant of when we used to do grand rounds on Thursday mornings. And so it was just like grand rounds and then we'll go straight to academic half day. And now that we don't do it and it's not linked, there's no reason why we should. But yeah, I'm still of the mind that someday we'll go to an X+Y schedule, and that's my thing. And if we ever go there, then we have to relook at the whole entire thing anyways. So, you know, if that's something that we ever go to, then we'll deal with it at that point. And if it looks like we'll never get there, then we'll readdress the thing about flip-flopping.
Yeah.
Anyways, I'm gonna step off if that's okay with the two of you. Thank you.
Hi, John.
Have a good
Have fun
day.
in Ohio.
Yeah, we've talked about that.
Yeah.
Okay, bye.
Bye.
I'm gonna go work in the kitchen for a few minutes.